Good day, everyone. Today's lecture will be on differential diagnosis of unconsciousness. So what is unconsciousness? Unconsciousness can be defined as a partial or complete loss of consciousness with interruption of awareness of oneself and one's surrounding. It can also be described as one who does not respond to sensory stimulation, for example, to shake and shout. Someone who has lost protective reflexes, for example, swallowing or coughing, and someone who is unable to maintain a pattern away. Fast and others reported that loss of consciousness was the most common reported emergency situation in dental practice. Loss of consciousness can lead to a medical emergency. Medical emergency can be defined as an acute injury or illness that possesses an immediate risk to a person's life or long-term health, and this requires an immediate action. The management of a medical emergency is an ethical, moral, legal, and professional obligation owed by oral healthcare personnel to any patient who enters the dental clinic. The United Kingdom GDC has come up with a standard for dental professionals. It emphasizes that all dental professionals are responsible for putting patients' interests first and acting to protect them. This will ensure the ability of the dental professional to deal with medical emergency that may arise. So there is a need to prepare ourselves for a medical emergency. Why? Because to prevent the preventables and to deal with the unavoidable in the quick, effective, and calm manner. Gutler and Smith reported that the most common medical emergency in dental practice are vasovagal syncope, which contribute about 63% of all the cases. Angina contributed 12%, hypoglycemia and epileptic fit 10%, choking and asthma 5%, cardiac arrest 0.3%. So looking at the incident rate of medical emergency in our dental practice, we need to come up with a preventive measure. To prevent a medical emergency, we need to know all the potential risks. We need to be able to take all the necessary precautionary steps, and we need to be able to provide a stress-free treatment environment. It is important to take a proper medical history, the past and present, and being able to perform clinical evaluation and examination. These include measurement of the vital sign, visual inspection of patient, and functional tests. This is to determine the patient's ability to tolerate stress physically and psychologically. The need for modified treatment to individual patient in order to reduce stress, to determine the need for appropriate use of sedation technique, and to determine any contraindication to any medication being used. One of the methods to assess the patient ability to tolerate the treatment plan for them is to utilize the American Society of Anaesthesiologists Physical Status Classification System, also known as ASA classification. The ASA Physical Status Classification System is a system for assessing the fitness of patients before surgery. It was introduced in 1963 with a 5-category physical status classification system. Later, the 6th category was added. It is a simple categorization of a patient's physiological status to help predict operative risk. This is the ASA classification. ASA 1 refers to healthy patients. ASA 2 refers to patients with mild to moderate systemic disease caused by the surgical condition or by other pathological processes and medically well controlled. ASA 3 refers to patient with severe disease process which limits activity but is not incapacitating. ASA 4 refers to patient with severe incapacitating disease process that is a constant threat to life. ASA 5, moribund patient not expected to survive 24 hours with or without operation. And ASA 6 refer to declared brain dead patient whose organs are being removed for donor purposes. As mentioned before, ASA 1 refers to a healthy patient. ASA 2, a patient with mild systemic disease with no functional limitation and has a well-controlled disease of one body system. Example of this is those with controlled hypertension or diabetes without systemic effect, cigarette smokers without chronic obstructive pulmonary disease, those mild obesity patient, and pregnant women. Example of ASA 3 patients include poorly controlled diabetic patient or poorly controlled hypertension, patient with chronic obstructive pulmonary disease, patient with morbidity obesity, that is BMI more than 40, patient with active hepatitis, and patient with end-stage renal disease but undergoing regular scheduled dialysis. Example of ASA 4 patient includes patient with recent history of myocardial infarct, less than 3 months, patient with cerebrovascular accident, patient with ongoing cardiac ischemia or severe valve dysfunction, patient with sepsis, and patient with end-stage renal disease which do not undergoing regular scheduled dialysis. Example for patient with ASA 5 include those with ruptured abdominal and thoracic aneurysm, patient with massive trauma, and patient with intracranial bleed with mass effect. Stress reduction protocol plays one of the important role in the prevention of medical emergency. This involves the recognition of medical risk and anxiety, appropriate medical consultation if uncertain, and the need for pre-medication. These are examples of stress reduction protocol. Appointment scheduling. Appointment early in the day will give a high degree of flexibility in patient management, less time to worry, and there will be ample time to manage post-op complication if it arises. Second reduction protocol involves minimizing the waiting time. A long waiting time will allow patients to smell, hear, and fantasize the worst. This will alleviate their fear and anxiety. Monitoring of vital signs is also a stress reduction protocol. This needs to be done pre and post-operatively. The other stress reduction protocol is to utilize psychosedation during therapy. This can be done using drug or without drug. For non-drug psychosedative therapy, example is hypnosis. For those with pharmacosedation, this can be given via oral inhalation, intramuscular, and IV sedation. General anesthesia can also be utilized for stress reduction protocol. Adequate pain control is also another important stress reduction protocol. A proper injection technique is required to control pain during the treatment. And duration of treatment also an important stress reduction protocol. Example, a multiple short visit will be appropriate for a medically compromised patient. Now let us look at the management of unconsciousness. It is very important for us to be able to recognize the early warning sign of impending collapse. We need to act immediately if such incident occurs, and very important to always remain with the patient and call for help. Knowledge of first aid is very useful in preparing ourselves when managing an emergency cases. It is important to remember that there are three P's in first aid: preserve life, prevention of the situation from becoming worse, and to promote recovery. First, you have to stay calm, remain calm. Then lie the patient flat. This will improve this will improve the blood circulation. Then clear and maintain the airway. Provide oxygen if available. Then check for breathing and feel for pulse. If absent, prepare to begin cardiopulmonary resuscitation. If patient collapses in the dental chair, remove any environmental hazard around the patient, for example, dental instrument tray. Lower the chair into a horizontal position. This will improve the blood circulation. Then the person in charge of monitoring the ventilation ideally should be positioned at the head end of the chair. And for those performing chest compression, they should be positioned at the side of the patient. So what is cardiopulmonary resuscitation? It is an emergency procedure that combines chest compression with artificial ventilation in an effort to manually preserve intact brain function until further measures are taken to restore spontaneous blood circulation and breathing. So how do we perform CPR? First, put the patient on his or her back on a firm surface. Then kneel next to the patient. Make sure you are at the chest level. Then place the heel of the hand over the center of the person's chest, that is at the xiphy-sternum junction area. Then place your other hand on top of the first with the finger interlocking each other. You also need to keep the elbow straight and position the shoulder directly above the hand. Then apply compression on the chest to at least 2 inches or 4 to 6 centimeters. Use your entire body weight, not just the arm, when compressing the chest. You need to push the chest at the rate 100 to 120 compression per minute. Then you must allow the chest to spring back after each compression. This slide is to show you how to place your hand during the CPR. Okay. First, identify the xiphy-sternum junction area. Then, identify the junction area. Then, place the heel of your palm of one hand on the xiphy-sternum area. And then place the other hand on top of the first with the finger interdigitating each other. Then, press or push the chest to about 4 to 6 centimeters. And then allow the chest to spring back after each compression. This is how you do the compression of the chest. Make sure the elbow is straight. If the patient is on the dental chair, this is how you position yourself for the CPR. The person in charge of maintaining the ventilation should be positioned at the head end of the dental chair. By doing chief lifting and tilting the head, this will open the airway and allow a better ventilation. And the person in charge of compressing the chest should be positioned at the side of the patient. Rescue breathing is given after a certain number of chest compression. This can be given through mouth to mouth or mouth to nose. In order to do a rescue breathing, the head needs to be tilted and the chin needs to be lifted in order to open the airway. Then prepare to give 2 rescue breaths. Give the first, watch to see if the chest rises. If the chest rises, give a second breath. If the chest does not rise, repeat the chin lift and head tilt and give a second breath. This will make sure that there is no blockage of the airway. Then resume chest compression to restore the blood flow. This is to show the chin lift and the head tilt maneuver. So if you can see, when the patient is lying down, the tongue is actually blocking the airway. So by doing a chin lift and head tilt maneuver, that will open up the airway. Every time you give the rescue breath, observe the movement of the chest. Moving chest meaning the air is going into the lung. This is just to summarize the whole CPR procedure. You need to give 30 compression and 2 breath for adult patient. In child, you give 15 to 1 ratio. The rate of compression is 100 to 120 per minute. The depth of compression is about 4 to 6 centimeter. Then we need to reassess the patient pulse and rhythm every 2 minutes or after 5 cycles of CPR. Then we need to stop the CPR when the patient is revived and start breathing on their own. If an automated external defibrillator, which is a life-saving device that is designed specifically to treat people experiencing sudden cardiac arrest, is available, you can use it. You can give 1 shock, then resume chest compression for 2 minutes, and then give a second shock. These are the common causes of collapse in dental surgery: fainting, hypoglycemia, fits, cardiac arrest, adrenal crisis, anaphylactic shock, and choking. Fainting is a vasovagal syncope. It is due to a transient loss of consciousness due to decreased blood flow to the brain. This is the most common cause of collapse in dental surgery. What are the precipitating factors? Pain, fear, postural hypotension, and excessive heat. These are the clinical signs of fainting: restlessness, sweating, cold hand, nausea and vomiting, depressed breathing, and loss of consciousness. How do we manage fainted patient? Lie the patient flat, meaning in supine position, with the feet raised above the level of the head. This will improve the blood circulation, the cerebral blood circulation. You should expect a rapid recovery. If vomiting occurs, the patient should be placed on their side to prevent aspiration. The second most common cause of collapse in dental surgery is hypoglycemia. Hypoglycemia is a state of low blood glucose level, which usually occurs in a non-diabetic patient. So what contributes to hypoglycemia in diabetic patient? The factors that may contribute include patient ignorance about the disease. Patient may have taken larger dose of medication than needed. Patient might have missed their meal or late meal. Patient may have been waiting for a long periods of time. Patient intake of insulin to food ratio is higher than usual. It may occur in pregnancy, especially after exercise, and prolonged fasting and alcohol abuse. This can contribute to hypoglycemia. So what are the signs of hypoglycemia? The signs are shakiness, dizziness, sweating, hunger, irritability, pale skin color, warm, moist skin, drowsiness, and disorientation. How do we manage hypoglycemia? If the patient is conscious, we can give oral glucose. If the patient is unconscious, first of all, protect the airway. And then place patient in lateral or recovery position. Then give IV dextrose, either 50 to 100 ml of 50% dextrose or 200 to 300 ml of 10% dextrose. Then you should expect a prompt recovery. If not, we need to give 1 milligram of IM glucagon. One thing to remember, never give insulin to a collapsed diabetic patient. The next cause of collapse in dental surgery is epilepsy attack. This is caused by an abnormal and spontaneous electrical activity in the brain. It may be precipitated in non-epileptic patients by starvation, flickering lights, alcohol, menstruation, and application of certain drugs, for example, methotrexate. These are the warning signs of a seizure, which include staring, jerking movements of the arms and legs, stiffening of the body, loss of consciousness, breathing problems or stopping breathing, loss of bowel or bladder control, and falling suddenly for no apparent reason, especially when associated with loss of consciousness. There are two types of seizures, focal seizures and generalized seizures. Focal seizures is when seizures appear to result from abnormal activity in just one area of the brain. This happens without loss of consciousness. It may alter emotion or change the way things look, smell, feel, or taste. It may also result in involuntary jerking of a body part, such as an arm or leg, and spontaneous sensory symptoms, such as tingling, dizziness, and flashing light. Generalized seizure, on the other hand, involve all areas of the brain. There are 6 types of generalized seizures. The first one is absent seizures. This is previously known as petit mal seizures, often occur in children. This is characterized by staring into space or subtle body movement, such as eye blinking or lip smacking, and this may cause a brief loss of awareness. The second type of generalized seizure is what we call tonic seizures. This causes stiffening of the muscles and usually affect muscles in the back, arms, and legs. Atonic seizures is the other example of generalized seizures. It is also known as drop seizures. This causes a loss of muscle control, which may cause to suddenly collapse or fall down. The fourth type of generalized seizure is clonic seizures. These are associated with repeated or rhythmic jerking muscle movement and usually affect the neck, face, and the arms. The fifth type is myoclonic seizures. Usually appears as sudden brief jerks or twitches of the arms and leg. And the last type of generalized seizure is called tonic-clonic seizures, which is also known as grand mal seizures. This is the most severe type of epileptic seizure. It can cause an abrupt loss of consciousness, body stiffening, and shaking. And this may result in loss of bladder control and biting of the tongue. So how do we manage patients with seizures? First of all, we have to clear all dental instruments away from the patient. Then we need to place the dental chair in a supported supine position as near to the floor as possible. This will minimize injury if there is a fall to the floor. Then do not restrain the patient and do not put your finger in the patient's mouth or try and put anything in their mouth for them to. We need to time the seizure. Call for emergency help if seizure lasts more than 5 minutes, or the patient experiences repeated seizures. We need to loosen any tight clothes around their neck and loosen the belt. This will protect the patient, and please protect the patient dignity. Call emergency if the patient looks cyanotic. We need to administer oxygen. And if the seizure lasts longer than 5 minutes or repeated seizures happen, we can administer buccal midazolam or appropriate anti-epileptic drugs. Be aware of the possibility of compromised airway or uncontrollable seizures. Once the seizure is over, place the patient in the recovery position. Okay, cardiac arrest is the other cause of collapse in dental surgery. It may be due to primary cardiac failure, for example, for those patients with history of acute myocardial infarct. It can also be due to primary respiratory failure, for example, in patients with history of obstructive airway and respiratory depression. So who are the patients at risk of developing cardiac arrest? Patients with history of hypertension, unstable angina, and previous history of acute myocardial infarct are at risk of developing cardiac arrest. These are the signs and symptoms of cardiac arrest. Patient may complain with central chest pain, anxiety, breathlessness, nausea and vomiting, and dizziness and syncope. And the clinical sign of cardiac arrest includes tachycardia, cyanosis, dilated pupil, collapse, no carotid pulse, heart or breath. So how do we manage a cardiac arrest? It is important to realize that the irreversible brain damage occurs after 3 minutes. So we have to act quickly and immediately. Perform airway breathing circulation assessment and commence cardiopulmonary resuscitation. Okay, the last cause of collapse in dental surgery that I want to discuss is anaphylactic shock. Anaphylactic shock is a potentially life-threatening allergic reaction to an agent, for example, penicillin. The reaction can be very mild or very severe. Mild reaction include itchiness, especially in the axillary and groin area, feelings of anxiety and panic, development of erythematous or urticarial rashes, and swelling or edema of the face and the neck. Severe reaction may include bronchospasm, which will lead to wheezing, laryngeal edema, which result in dyspnea, stridor, drooling, and aphonia, hypotension, which may result in shock, and arrhythmias and cardiac arrest. So how do we manage anaphylactic shock patient? First of all, stop the administration of the causative agent. Then place patient in a recumbent position and elevate the lower limbs. Then assess airway, breathing, and circulation. Then we need to give IM adrenaline 1 in 1000 and repeat every 5 minutes. Anaphylactic shock has a cardiovascular and respiratory manifestation which require the use of adrenaline. This will reduce the body's allergic response. We also need to give IV antihistamine and IV steroid in order to reduce inflammation of the airway and improve breathing. And a bronchodilator, for example, beta agonist, can be given or also need to be given to the patient to relieve breathing symptom. Example of a bronchodilator is salbutamol. Okay, so that will conclude my presentation today. Thank you for listening and hope to see you again. Thank you very much.